Okay, good morning, everyone. So I'm pleased to talk about milk protein allergy, which is something that I've been interested in for about 20 years. As a full disclosure, I'm residing in the U.S., but I'm originally Finnish, born and raised, so we have more Europeans in this session, in fact. So here are my disclosures. I also get royalties from UpToDate, and most importantly, I'm funded through the National Institutes of Health, United States, as well as Bill and Melinda Gates Foundation, to look at the role of development of food allergies, particularly milk allergy. So when we talk about food allergy, really the definition of it is that it's an immune system-mediated adverse food reaction, and it can be divided into three different categories. IgE-mediated, mixed etiology, and the non-IgE-mediated. The IgE-mediated presentation is certainly the most famous, most well-known, including anaphylaxis, food-dependent exercise-induced anaphylaxis, urticaria, angioedema, immediate GI symptoms, bronchospasm, and pollen food allergy syndrome. Whereas the non-IgE-mediated includes things like celiac disease, certainly well represented at this meeting, as well as allergic proctocolitis, and food protein-induced enterocolitis that are commonly caused by cow's milk. And the mixed etiology includes, most importantly, the eosinophilic gastroenteropathies, including esophagitis and gastroenteritis, that are commonly also caused by cow's milk. Prevalence of food allergies. So in infants and children, we see that about 6 to 7% of children are impacted by food allergy, with cow's milk, egg, and peanut being the most common food allergies. And really, cow's milk allergy prevalence varies probably between 2 and 3%. Depending on the different series. And shown here in white, you see cow's milk, egg, soy, and wheat highlighted because those are the food allergies that typically outgrow, leaving peanut, tree nut, fish, and shellfish something that is typically retained until adulthood, and therefore the prevalence of adult food allergy is about 3 to 4%. So we know that the prevalence of food allergy varies between different locations, geographic locations, and countries, even within Europe. Estimates vary from 1 to 2% for food allergy in low prevalence countries to all the way to 10% in Australia. And importantly, the self-reported milk allergy and food allergy is probably 3 to 4 times more common than that is confirmed by food allergy testing, typically oral food challenge, which is considered the gold standard for establishing the diagnosis. So as an example, this meta-analysis from Europe-Preval study done in Europe showed that particularly milk is probably more susceptible to this self-perception of having high prevalence, shown here, self-reported prevalence of 3.5% for milk allergy, but only 0.6% for symptomatic and sensitized, and less than 1% prevalence when confirmed by oral food challenge. So a lot of people think that they have food allergy, but in fact, that may not be the case when we use very strict criteria for making the diagnosis. So the cow's milk allergens are very well known, well established, caseins and whey proteins. I'm naming here the most important milk allergens. And the epitopes on these, the allergenic parts of the proteins are well known. Our group and others have characterized the allergenic epitopes that are binding IgE antibodies. Most importantly, those include caseins, but there's also sensitization to whey proteins, including beta-lactoglobulin and alpha-lactalbumin. And most people with milk allergy actually are multi-sensitized, so they have IgE antibodies against many of these proteins. And interestingly, the cow, goat, and sheep being all ruminants, there is a close resemblance between proteins between these milks, and there's high level of cross-reactivity, whereas cross-reactivity between milk and cow's milk, camel, and pig milk is less common, and the clinical cross-reactivity between cow, horse, and donkey is even less prevalent. It's very well established that food allergy is a growing clinical problem. As shown here in this graph, for peanut allergy in the US, we know that there was a doubling from 1997 to 2003, and a further doubling until 2008. And this trend has unfortunately continued. We do have similar data from other continents, including Canada, United Kingdom, and Australia. And we know that there is an 18% increase in all food allergies. However, this increase in food allergy does not seem to impact all foods equally. And very recent data from the paper in Pediatric Allergy and Immunology showed that the ED visits and hospitalization that was done due to food-induced anaphylaxis, there was an increase about 3 to 4 times for peanut and tree nuts, whereas the increase for milk allergy was perhaps only twice in the last couple of decades. So if we talk about the different presentations of food allergy, this is important to make a distinction between them because the diagnosis and natural history is very different. IgE-mediated food allergy is the most common. It represents with hives, swelling, sneezing, congestion, GI symptoms, abdominal pain, vomiting, sometimes diarrhea, and there's asthma, bronchospasm that gets elicited in some individuals. And certainly the best treatment for this is self-injectable epinephrine, and the diagnosis is rather easy because IgE testing, skin prick testing is typically positive in these individuals. However, the non-IgE mediated and mixed etiologies include things like allergic proctocolitis that is typically caused by cow's milk, and it presents by 6 months of age, and typically you see blood-streaked mucus-eluted stools in either breastfed or formula-fed infants who are otherwise completely well-appearing. So they're typically not suffered by this. This is an eosinophil-dominant inflammation, and cow's milk, soy are the most common triggers, although viruses can cause a similar presentation for a certain amount of time. And really, with complete elimination of milk from mom's and infant's diet, the clinical bleeding typically resolves in about 3 days. Food protein-induced enterocolitis. I have not heard as much at this meeting about this, so it's important to go over the clinical presentation because there's the diagnosis really made by clinical rounds. So in its acute presentation, it typically starts in early childhood, in infancy, and it presents with emesis that is protractive in 2 to 4 hours after ingestion of the food protein. There seems to be this delay in these symptoms that is different than IgE-mediated symptoms. And these children also present with septic appearance, they're lethargic, they're gray, ashen look to it, and some of them even go into shock due to dehydration. There's sometimes diarrhea that follows in hours or next day. And typically this presentation, this classic acute presentation, happens after a period of avoidance of this food. And in blood work, you would see increased white count cell and acidemia, which further points towards a septic sort of workup that is oftentimes done for these children when they present in the ED. The common triggers include cow's milk and soy, as well as rice and oat. And its chronic presentation, which is much less seen at this point, we see watery diarrhea, failure to thrive, mucousy stools, and this intermittent and less prominent emesis that happens typically with continuous exposure to cow's milk formula or soy formula, and you would see low total protein as well. What I have heard more in this meeting is allergic eosinophilic gastroenteropathy that impacts either the esophagus or the lower GI tract, and typically presents any age from infancy to adulthood with reflux, symptoms, dysphagia, failure to thrive, sort of irritability, taking a long time to finish your meals, and things of that nature. The lower GI disease is less commonly impacted, and those individuals would have failure to thrive, typically anorexia, sort of chronic pains, and even hypoalbuminemia. And a common trigger, again, the most common trigger for this disease is cow's milk. So as a clinical immunologist, I'm going to show you one slide of immunology, and that's it, I promise. I want to make friends here, not enemies. So we have here cow's milk. What happens? How does the sensitization and effector phase, how does it happen? So we need protein digestion, and this breakfast including milk and wheat as a possible protein as well. And this antigen is processed by antigen-presenting cells and then presented to T cells. And these T cells, particularly the Th2 type cells, are orchestrating the B cells to produce specific Ig antibodies to milk protein that are then bound by high affinity IgE receptor or mast cells, the bad guy here. And upon re-exposure to the same food, these allergenic parts or the epitopes are cross-linking consecutive IgE molecules. And this results in release of preformed mediators, such as histamine from these granules. That those are responsible for the typical manifestation of flushing and so forth. There's also a de novo synthesis of lipid mediators. IL-4 is a key cytokine that is responsible for these IgE antibodies as well as mast cell upregulation. There are mechanisms that are suppressing clinical reactivity that includes IgA antibodies and IgG antibodies that can be blocking antibodies, and they can neutralize the food antigen. But also T regulatory cells are suppressing Th2 and mast cell activity, and those are key in developing tolerance to these foods. The non-IgE mediated presentation has a much more variable etiology and probably includes a TSLP, TGF-beta, and IL-5, and so forth, different cytokines, but those are not very well understood. So this next question is obvious. Increasing food allergy, why is this happening? Well, I'm using the nice graph from Gideon Lack and George Dutroux from a couple of years ago, where they really highlight that there are probably 3 different dominant hypothesis at this time. The vitamin D hypothesis, less vitamin D might be responsible for more allergic diseases and asthma, are somewhat debated still at this point. There's the hygiene hypothesis that exposure to more diverse microbiome might be actually inducing tolerance. And then there's dual allergen exposure hypothesis, which includes that in normal individuals, there are dendritic cells, the CD103 positive dendritic cells that are rather tolerizing in the GI tract. They develop. In most of us, we become tolerant to food, and that results in the development of these T regulatory cells that I talked about that are suppressive. However, skin can be a very sensitizing route. You can have filaggrin mutation that we heard about yesterday, or just having eczema on the skin, and household exposure to food proteins more commonly shown for peanut can be a rather sensitizing route. So these dendritic cells that are in the skin can be rather sensitizing, and they can be responsible for the upregulation of IL-4 that we just talked about, and this Th2 type memory. And this situation can be particularly problematic when you are continuing exposure through the skin, but you are avoiding exposure through the oral route that can be typically rather tolerizing. And this certainly was well demonstrated in the landmark paper by the same group, showing that peanut introduction in high-risk infants that have significant eczema at early ages, 4 to 11 months of age, can be a very powerful tool for preventing food allergy. So inducing tolerance by eating it can result in significant risk reduction for peanut allergy. However, although this is being shown in this nice randomized trial for peanut, it is not known for sure, and the study so far has not been done, whether the same applies for other food allergens, such as milk, shown here. We have some, what I would call, circumstantial evidence that perhaps the tolerance develops similarly. Most children who develop eczema, who develop milk allergy, also have eczema, and a random bottle of milk formula in a nursery can be sensitizing. But if you start early introduction in the first weeks of life and continue, that can be rather tolerizing. So the jury is still out there. What happens with milk? So there really seems to be this window of opportunity that probably includes not only the infant exposure to feeding practices, C-sections, early life antibiotics, but also includes maternal exposures. And really, within the first few months of life, there's housing, pets, farm lifestyle, and diet, in addition to allergen and microbial exposures that can shape the immune system to either tolerance or sensitization. And there's certainly a lot of data by now on asthma and some other allergic diseases that farm life can protect from development of asthma and allergic rhinitis. The jury still out there whether this also protects from food allergy, particularly milk allergy. And our group and others are heavily working on this topic to figure this out. We're using old order Mennonites as a study population that brings us 150 years in time, sort of seeing how does the lifestyle back in the day, how did that protect against allergic diseases. So really, one key question that I then in this setting typically get, well, what about breastfed infants? What happens with breastfeeding? Does it sensitize? Does it tolerize? And we certainly know that beta-lactoglobulin is present in breast milk. It's a protein that is not present in endogenous breast milk. So whatever is found there is from maternal diet. But it's found in very small levels, as you see here, and not every mom secretes any. And we do know that this can induce symptoms in highly sensitized individuals. So not in most, but in some highly sensitized babies, they can develop symptoms as shown here with this baby developing eczema and rashes with maternal milk consumption. And then when mom's diet was eliminated from cow's milk, the skin was nice and clear. And we can also show that then re-exposure to milk protein through mom's diet can re-elicit these eczema, maculopapular rashes. But we don't really know whether these small levels of protein are responsible for initial sensitization or tolerance development. And you could argue that these low levels of antigens present in breast milk could be rather sensitizing, but when they're being given together with breast milk immune factors such as IgA, TGF-beta, HMOs, we heard about this yesterday a great deal, and microbiome, that could perhaps be much more tolerizing. And again, the jury is out there, and we are working very hard on this question. As a summary, the resolution of milk allergy is rather favorable. IgE-mediated food allergy and cow's milk allergy outgrows by about 80% by the beginning of early adolescence. Recurrence is extremely uncommon. Once you're outgrown for good. The ease of tolerance development probably has to do with recognition of linear epitopes on milk proteins, and tolerance of baked milk is a good prognostic sign that tolerance is on its way. The non-IgE-mediated manifestations have a rather favorable prognosis. Most outgrowing procticulitis by 1 year of age, FPIs by 3 to 4 years of age. However, for EOE, there's variable prognosis development, or tolerance development, so the prognosis can be rather variable. So with that, I wanted to end my talk here and open the podium for other speakers, just showing a couple of slides about our clinical practice, our lab group at the new Gallisano Children's Hospital in upstate New York. Thank you very much.